Good afternoon, everybody, or good evening, or good morning, depending on where you're joining us from. My name is Caroline Brown, and on behalf of Hamilton Medical, I'd like to welcome you to this second webinar in our Experts on Air series on high-flow oxygen therapy. Today, we're delighted to have Dr. Tommaso Mauri from Italy and Dr. Jens Bräunlich from Germany joining us to talk about optimizing settings. For those of you who didn't join our first webinar, just a couple of things to note. This session is being recorded, and a link to the recording will be sent to you by email within a few days of the event. And just the second thing, your cameras and microphones are switched off by default, but we would love you to join using the Q&A function. So if you have any questions, please feel free to place them at any time using the Q&A tool. And now, with no further ado, I'd like to hand over to our experts. Gentlemen, the stage is yours.
Hello to all. First, I want to thank Hamilton Medical for organizing this webinar. The topic today is how to optimize nasal high flow therapy input from physiological studies. My name is Jens Bräunlich from Germany, and I'm the chair of this session, and I will interview Tommaso Mauri. And first of all, I want to give you two questions for the beginning, and I will start now, and you can vote in 30 seconds. To look at this voting. Please vote. The question is, what is your initial flow setting on nasal high flow therapy?
Yes, there is no right answer. We just want to know what you do in reality.
Exactly.
As you start.
Okay, I will wait a few seconds. And the most points, I think we can say this came to 30 or 40 liter per minute. And the second place goes to, these are not Olympic Games, is to 50 and 60 liter per minute. Okay, thank you.
Yeah, a lot of heterogeneity, a lot of differences. This means that there is no consensus on how to select settings, exactly what we speak about today.
Okay. I will give you another question now, and we are also interested in your idea about this topic. The topic is, which parameter do you use to titrate the flow rate during high flow therapy? So now you can vote.
So with this, we are also suggesting that you need the gold. You just don't put the flow and go away. You check the effect.
Okay, that's very interesting. Yes.
Yeah,
we have the same place for respiratory rate, SpO2, and patient comfort, and the ROX index is a little bit on the, I would say, second place. Yeah, and all the other things in on the first place. Okay, I will show you the results. Once again, this is what we see. Very interesting. This is good to speak about this topic. There are many differences, I think so. And we will show you some interesting things from the physiological point of view. Now, it's a pleasure to introduce Tommaso Mauri from Milano as my interview partner today. He is a well-known researcher in the field of nasal high flow therapy, and he published a lot of very high quality papers in this field. And I would say from my point of view, he is a source of inspiration in this field. And Tommaso Mauri has prepared a presentation to bring us a little bit in the topic. And Tommaso, please start.
Yes, I'm sharing the screen. So I'll try to be brief, and the presentation will mostly be based on later discussion. But I try to keep in mind also the question that arrived before the webinar. So the point is to optimize. These are my conflicts. Okay. So what is high flow? High flow is a range of flow. So you can set humidified and heated gas through the nose, and the minimum is usually thought to be around 30 liters per minute, the maximum to 60, but in reality many machines, many commercially available devices, and also clinical experience is growing, can let you deliver high flow up to 100, 120 even liters per minute. So you can set for sure the flow. You can set the FiO2. The FiO2 is the one you desire. High flow is not necessarily a lot of oxygen. You can even do high flow, and we do sometimes with the room air. And you can set the temperature because it's heated and humidified. So the idea is that high flow is not just a lot of oxygen. It's a complex interaction between the physiology of the patient and these settings that you put on your machine. The desired effect in most patients, especially in hypoxemic patient, in postoperative patient, is to decrease inspiratory effort, because the inspiratory effort if there is no support is directly translated through transpulmonary pressure. So you generate a negative swing, and that translates directly to the pressure across the lung. This is very different from an IV, for example, from positive pressure ventilation. So if you have a condition where you have some oxygen and then high flow nasal cannula, and with high flow nasal cannula you decrease effort, so lower inspiratory effort, you decrease directly the transpulmonary pressure and the risk for additional injury to the lungs of the hypoxemic patients. How is this possible, and how flow affects these effects of high flow? So one effect that is very clear for high flow once you put it on is that you increase PO2. So for the same FiO2, you increase the PO2. So you increase the PO2 FiO2 ratio. So high flow improves oxygenation, and this looks a little linear with flow. This is facial mass 30, 45, 60. The more you increase the flow, the less hypoxemic is the patient. These are data in hypoxemic patient. Why you improve oxygenation? Probably because the FiO2 in the alveoli is more similar to the one that you set. So you set 50% FiO2, the flow is very high. So even if the patient has a strong inspiratory effort, you don't have room air going in, and the FiO2 is more similar to the one you set. And this is, again, mostly linear with the flow. And then there is the PEEP effect. PEEP effect, you asked about the range, is low, is around 3-5 centimeters of water. There are data showing that if you go up with the flow 60, 80, you may arrive to 5-7 centimeters of water, but the comfort of the patient may not be so good. So some PEEP effect, distension of the lungs, recruitment, and improved FiO2. And then there is the CO2 side, because high flow is effective both on the oxygenation side and the washout of CO2 side. So you have this washout of the upper airways that decreases the need of breathing of the patient. You can have the same minute ventilation with lower CO2, or the same CO2 with lower minute ventilation, which is the same. So for the same amount of CO2 to be cleared, you need a lower ventilation. This decreases inspiratory effort, and this effect it's difficult to measure it, but there are some data suggesting that it's not linear, that after you go above a certain threshold, you don't obtain much more advantage anymore. And this threshold is around 30 to 40 liters per minute. So while the oxygen side of high flow increases linearly with the flow, maybe the washout of CO2 side has a threshold effect above 30-40 liters per minute. And these are the data and the references if you want to take a look. You can go to higher flows than 60. We went up to 100, 110. The physiological effect were there. So the PEEP effect increases with the higher flow. The oxygenation improves. But the comfort of the patient, we showed in this study published in 2020, may become very poor. So the tolerance of the patient may become suboptimal. So comfort is an issue. However, physiological effects are higher level for flow higher than 60. Then we measured the effect on comfort as a global, let's say, global indicator of the effectiveness of high flow, modifying the temperature and the flow. And we saw that temperature, which is correlated with humidification. So the higher the temperature could be, the better, but higher temperatures are correlated with poorer comfort. So sometimes we prefer in an hypoxemic patient to leave a higher flow, a little lower temperature, so you have all the beneficial effects of flow without the discomfort of the high temperature. And finally, there is the cannula that you can select. There are different sizes, different brands, whatever, but the most important point that this study showed is that is very recent data, is that if you have a larger cannula, you may have a larger PEEP effect for hypoxemia, good for hypoxemic patient. If you have a smaller cannula, you may have a larger CO2 washout effect, so faster washout of CO2. So maybe larger cannula for hypoxemic, a smaller cannula for a hypercapnic patient could be another setting that we can check and decide. And finally, as we suggested in the beginning with the poll, you need, I don't know, Jens, if you agree, but you need some goal. What is your goal? The target variables for you to set high flow and to see that it's beneficial for the patient. I like the ROX index. It was the least voted in the poll, but I like it. SpO2 divided by FiO2 divided by respiratory rate. Very easy variables to obtain at the bedside. And we showed that if you increase flow and the ROX index improves, actually that patient probably benefits from higher flow and from high flow itself. In fact, instead, if you increase the flow and the ROX index remains stable or decreases, it means that the patient may not need the therapy, doesn't have much benefits from that therapy. So one index that is more related to the effort and the respiratory status is the ROX index. Otherwise, we also use comfort as a target variable to set. So to conclude this first more formal part, I would say that we need a personalized approach to set high flow. You can select the flow and maybe higher flow for hypoxemic, intermediate flow for hypercapnic. This is very schematic and you need a goal at the bedside, but just to make some key points. FiO2, you set it based on saturation that may differ the range between hypoxemic and hypercapnic after you select the flow. First you set the flow, then you select the FiO2 for a certain range of SpO2. Temperature, I would say the highest tolerated, highest temperature is better for humidification, but may lead to poor comfort, so it's a balance. The cannula size are very new data, but maybe you could select larger for hypoxemic and smaller for hypercapnic. And finally, maybe ROX index or comfort could guide your bedside personalized setting. Thank you.
Okay, thank you very much, Tommaso. Very nice and excellent overview. And we want to go now in the Q&A section. We have a lot of questions there. And I want to start with the first one. In the meantime, please send us some more questions. We will answer this question in the sessions or after them, whatever you want. So I will start with a question from Annalisa, and it's very good to the problem of a smaller and a bigger cannula to wash out the CO2. Does it make sense to use a smaller cannula to increase CO2 clearance? What do you mean, Tommaso?
So I can say, first of all, what we do usually. We often, I work in the ICU, general ICU is very specialized on respiratory patient. And we all often have very sick patients, severe patients, and there is the problem of nasogastric tube. I don't know if you have the same in your unit. So it's different for outpatient, from patient in ward. So with the nasogastric tube, we are obliged sometimes to put a smaller cannula. We don't usually use very large cannula. But for example, if I will go to a COVID patient in the emergency department, severely hypoxemic, but COVID, so not much distress, happy hypoxia, as you say, as we learned, I will put, and without the nasogastric tube, I will put the largest cannula possible. Instead, for an hypercapnic patient, I don't know, either post-operative, you have a severe COPD undergoing general surgery, and you extubate him or her, and you want to support in the post-operative period. I think there a smaller cannula with a flow around 30, 35 is more than enough and very effective, yes. It depends if you have all this range of cannula, but these data show that it's good to have different sizes of cannula in your unit and in your hospital.
From a practical experience, I think this is a very interesting question. I have investigated COPD patients several years before with different cannula sizes, and I measured the capillary CO2. And I found no real differences between this, but in another study also from Fritzola in little pigs, and in my own study, we used the nasal cannula only in 1 ear to decrease the CO2. I think this is more effective, for my opinion, to decrease the PCO2 by the washout effect if you have a really higher increase of leakage. Not only the cannula size. I remember one patient on lung transplantation waiting for cystic fibrosis, and we use this only in one dose, and we have more washout of CO2 measured in the blood than another cannula. That's my experience.
I agree with you. I understand what you mean. So even the smaller cannula, we have to point out, because there are some people going around saying that it's the velocity of the flow. Maybe that's true, but it's also the mechanism that you are saying, that the washout is more effective because you have also larger port for the air to go out, as you said now. So either a smaller cannula or a large cannula, but only in one air, maybe do the same job, let's say.
Okay, we go to the next question. Are there significant differences regarding the PEEP between breathing with open or closed mouth? I think this is interesting and needs some clarification.
Okay, so the studies we did in our unit where we wanted to have the highest, let's say, clinical impact. So we didn't give instructions to the patient because it's impossible to tell the patient stay with your mouth closed for hours. I don't know, patient, and it's one of the advantages of high flow, that you can speak, that you can eat in comparison to, for example, the face mask of NIV. So I will not force the patient to keep the mouth closed, but these will end up in variability. We had variability. So the PEEP effect is highly variable if you leave the patient as is. I think that it's true. The mouth closed generates higher PEEP. The difference, I think, is within 1 or 2 centimeters of water. So I don't know how much is worth to tell the patient to keep the mouth closed. So I would say that the bottom line is with high flow treatment is inevitable in daily clinical practices to have fluctuation of the PEEP effect over time. And this may be even beneficial. Maybe it's some gymnastic for the lung. We don't know.
Okay. Then an interesting question for me. Do you think that the PEEP effect is the main mechanisms of action of nasal high flow? I think this needs clarification.
Okay. I think that we don't know. I think my experience with studies and patients is that there is large variability in the physiological response of the patient. So in some patients, the PEEP effect is very large. In some patients, you don't see. The other day, because we measure the PEEP effect usually with the expiratory lung volume. And the other day I was with 2 COVID patients, and one with the same flow, 40, had a significant PEEP effect. Around half of the tidal volume, means 3, 4, 5 even centimeters of water. And another one, the line of the end expiratory lung volume was flat. Nonetheless, the second patient decreased significantly the respiratory rate. So even though there was not much PEEP effect in this patient, the patient benefit from the treatment because the respiratory drive decreased. So I think that we don't know. We have to know that it's a mix of physiological effect, and in one patient can differ from the other the main mechanism of benefit. That's my experience mostly.
Good point. Yeah, we go to the next question. I will read it. You will find that patient comfort is higher when using 31 compared to 37.
Yes.
Yeah. Would you recommend using a more comfortable setting even if the optimal level of humidity is not reached? How often you would use them 30-30 degree?
So I will speak broader of higher versus lower temperature because those settings are related to one manufacturer, but then it can change.
Yeah.
In general, the highest is correlated with the highest humidity and saturation of water in the air. So we should aim to have the highest. However, sometimes high flow can be, I don't know if to say life-saving. There are some patients who do not tolerate NIV, but they are hypoxemic. So you really want them to stay on high flow. And for them, especially in the beginning of the treatment, maybe the first 1 hour, 2 hours, we leave a lower temperature, even the lowest sometimes. Yeah. Because I think, in my experience, that after the patient feels the benefit, he will or she will be also more willing to accept the higher temperature. Mm-hmm. So if after 1 hour the dyspnea decreased, there will be less a problem to increase temperature because the patient will feel the benefit of the. So yes, we even tolerate very low temperature, like the lowest, but for a limited amount of time.
Do you think the effect of the movement of your cilia is more in higher temperature than a lower temperature? Is there additional effect to the for the comfort in the humidity?
Yeah, there is a study on rabbits showing that. So we take the cold in the winter because we breathe air that is 0 or even less in other parts of the world, and the ciliar movement stops. There are data showing this. So for sure, higher temperature also helps the secretion of clearance with the ciliar movement. However, we are speaking here between 37 and 31. I don't know, but in Milan, 31 is rarely reached as a temperature, sometimes in July. So it's not I understand that it's very high flow and they are sick, but we don't have to worry as we are also used to breathe at much lower temperature. So I think even the lower temperature is acceptable.
Okay. I have an interesting question. How we can evaluate patient effort without esophageal pressure measurement? What would you recommend?
We are working on that. It's very difficult to tell. There are many studies saying that it's difficult. Very few studies suggesting alternative. Yeah. I like the ROX index. It's very easy and can be applied outside of the ICU very easily. The Borg scale in our experience doesn't work in hypoxemic patient. It's good only for hypercapnic patients. So asking between 0 and 10 the degree of inspiratory effort. If you have a central line, you can take a look at the swing in central venous pressure. If the inspiratory effort is very strong, you will see the central venous going down, but that's rare in non-intubated patient, I understand. Use of accessory muscle means too strong effort. So that's not the strength of the effort we want to detect. So in general, I would use patient comfort, a mix of patient comfort, gas exchange, very low PCO2 is usually associated with the strong inspiratory drive. If you have 27 of PCO2 with 7.5 pH in hypoxemic patient, means that the patient is breathing a lot. So it's a mix, but there is no single measure.
Okay, thank you. A long question, I think a short answer. Do you combine surgical mask and nasal bronchs in non-COVID patients to improve oxygenation?
We don't do that.
No, I fully agree with you. That makes no effect. Yeah. And very other interesting question, we spoke about the SpO2 target in hypercapnic patients, 88 to 92. Yeah. And the question is, why do you recommend such a low SpO2 target for the poor hypercapnic patient? I want to add that if you have also a decrease in hypercapnia, why we should use such a low SpO2?
Well, I don't know, but I think that not blunting the hypoxia drive. So the COPD patients are usually used to lower SpO2. And but when they arrive to the hospital and they have acute respiratory failure, they need to breathe more. And if you go to higher SpO2, maybe you could blunt the hypoxia drive, and this will increase PCO2. So as long as the patient is comfortable, I will target the lowest SpO2 that he can tolerate. I usually go around 98 and 88, and they do fine because that's the normal SpO2 that they have. And so you don't drag the center of breathing with oxygen. That's the risk.
One very interesting question. Is there a strategy to set different initial flows in hypoxemic and hypercapnic patients? But what would you recommend to do if you say the best effect of decreasing PCO2 in hypercapnic patients is 35? Is there an initial setting you would recommend in this both populations?
No, in my presentation, I followed what I usually also teach to residents. So you have to know of a certain treatment what is low and what is high.
Yeah.
And then you move, and then you need a target physiological variable to fine tune and titrate at the personalized level. So I wanted to give some ranges, knowing that for a hypercapnic patient, 60 is high and maybe 20 is low. And instead, in hypoxemic patient, I think that starting at 30 is low. Is not recommended. Then after you have an idea of the range of that patient based on the etiology, you can fine tune having a target physiological variable. It could be respiratory rate, effort, ROX index. That's what we usually do.
Okay. In which situations you increase the flow above 60 liters per minute?
It's interesting. In patients that you are left with not much choices, that would be my approach. For example, patients that do not tolerate an IV and you don't want to intubate. Hematologic patient like this, like patient that it's very risky to intubate, and you want to give the full non-invasive support. This is the idea, I would say. So you do not intubate, not palliation. I'm saying that you want to do full support, but intubation is too risky. This is the patient I would try the very, very high flow.
Yeah. One more question. Is it necessary to sedate the patients on nasal high flow? Do you ever seen this effect?
We usually don't do that. Sometimes if the patient was already sedated, for example, if you use high flow after extubation, either post-operative or after a prolonged intubation, maybe the patient is already on some Dex or remifentanil, and we usually keep it, but as a way to withdraw slowly. Usually not if it's if the patient is naive.
I think a last very interesting question. In a setting of high flow mode, is it better to start with higher flow rate and lower FeO2? What do you prefer?
Yes, depends on the patient. Usually with the hypoxemic patient, I will start with a very high flow and then titrate and the FiO2 the lowest needed. But instead with a post-operative or a COPD patient, I will start with the low flow and eventually go up if the desired effect is not reached.
Yeah. And the last patient, then we came to the end from me. Is there a role of a combination of nasal high flow and helmet?
We have a paper on the Blue Journal on that. It's very interesting. So yes, I think the combination of CO2 washout and non-fluctuating PEEP and high PEEP level of helmet may have a role. We will see that.
Yeah. And when do you would switch from nasal high flow to helmet CPAP?
When you need a higher PEEP in severely hypoxemic patient, PF below 100.
Okay. Very interesting. We are at the end of the time. Very nice presentation. Very nice questions. We will do something more on the Q&A section. I will write it now. And thank you to Hamilton Medical to providing this webinar. And I will give back to Caroline.
So that's it for today, everybody. Thank you very much for attending. And of course, a huge thanks to our two experts for their time and expertise. It's much appreciated. Don't forget that you'll receive a link to the recording within the next few days, as well as a link to the answers for any questions that we haven't been able to address during this session. So, and if you haven't signed up for future webinars in this series, just follow the link that's been posted in the chat and sign up now. So goodbye, thanks again, and we look forward to seeing you again very soon.
Bye.
Bye.